UPC can start now.
Yes, sir.
Hello, friends. It's an honor to have all of you to view this wonderful initiative taken by Indian Academy of Echocardiography. We at Indian Academy plan to present you this clinical cardiology or echocardiology rounds every month on the first Wednesday. That would be from 8 to 9 p.m. And not only we would discuss various topics, it we would try to cover entire cardiology spectrum as based on echocardiography. So we would take it kind of a topic by topic, so it's covered thoroughly right from the basics to the advanced, so that it's useful for novice, it's useful for the experts. Not only that, we are going to put this on our YouTube channel of Indian Academy of Echocardiography for those who missed it or those who want to revise it, or it is out of their time zone. I think all would be benefited. So we today have Dr. Shantanu, and I request Dr. Vora to please introduce Shantanu, and then maybe I'll tell you about bits about the topic what she's going to discuss.
Yeah. So, good evening, everyone, and a warm welcome to the IAE monthly clinical rounds. So, it is a pleasure to introduce our speaker for today, Dr. Santanu Sengupta. Dr. Sengupta is a heart failure specialist at Sengupta Hospital, Nagpur, and the current president of the Indian Academy of Echocardiography. He holds an MD, DNB, and PhD with his doctoral research in HFpEF from Newcastle, UK. He is a fellow of American College of Cardiology, American Society of Echocardiography, and an honorary fellow of the British Society of Echocardiography. He serves as an associate editor of Cardiovascular Ultrasound and is on the editorial board of JACE, and is also a reviewer for leading journals including JAC, JACE, JAMA, European Heart Journal, and several others. Dr. Sengupta has published extensively and notably became the first Indian cardiologist to present a late-breaking clinical trial at ACC 2023, a landmark achievement for an Indian cardiologist. He is also held important leadership roles as Program Director of Echo Nagpur, convener of the CSI Echo Council, and past president of the CSI and the Diabetic Association of India Vidarbha chapter. So the topic for today, LV systolic function assessment, the past, present, and future, is an extremely important in contemporary clinical practice. With evolving heart failure classifications, expanding therapeutic options, and increasing emphasis on the precision medicine, accurate and reproducible assessment of LV systolic function, well beyond a single ejection fraction value, has become central to diagnosis, prognostication, and treatment selection. So a clear understanding of the newer parameters and future directions is therefore essential for clinicians, echocardiographers, and trainee as well. So Dr. Sengupta's key areas of interest, that is heart failure with preserved ejection fraction, left atrial function, and LV mechanics, make him an ideal suited candidate or speaker to address this subject and translate science into day-to-day practice. And also beyond cardiology, he is also an Ironman and marathoner, reflecting the same discipline and endurance he brings to his professional life. So we are delighted to have him with us today. So over to you, Dr. Sengupta.
Thank you, Sunil, for such kind words. Thank you, Dr. UP Singh, and I also would like to acknowledge Dr. Parashar for taking this initiative. It's an amazing concept of putting up clinical grand rounds. So the main theme, which was shared by all the executives, that there is a need of updating our knowledge. So I'm showing my slides. Is the slides visible?
Yes.
Perfect. Great. So today I'm going to go a very extensive coverage of looking at the systolic function of the left ventricle, how the thing has evolved, and making everybody understand that it is one of the most important thing which every doctor, now every patient asks, the most famous thing from echo, which is ejection fraction. Everybody wants this number, but I think we should understand from where this concept of ejection fraction or the systolic function assessment has come. And I don't have any conflicts or disclosures. So before going to the thing, this is how the heart is looked when a surgeon opens up. And as you can see, that the heart is one of the most important organ with a very high performance pump, and it weighs almost around 300 grams, pumps around 8,000 liters of blood at rest every day. And when somebody exercises, this pumping increases, this activity increases. And in terms of mechanical work, this represents almost lifting of approximately 100 pounds, 1 million high. And as you can see that we have known that this occurs because of the twisting mechanics, twisting phenomenon. So this is the apex you can see, and the apex is moving anti-clockwise. So I will encourage that every medical person or every medical internist, whether you are in MBBS or an extensive studied person, should always see a beating heart, go to the OR and try to understand and see this. So the heart is a high performance organ pumping continuously non-stop. And the concept of cardiac performance has evolved from a Swan-Ganz catheter where invasively we could see, we can look at the cardiac output, stroke volume, get the pressures, and the heart was initially identified as a hydraulic pump. Then came the concept of compression pump, where an ejection fraction can be taken out, also looking at the pressure volume curves, the DPDT. Everything gives you an understanding of the LV performance. And this can be picked up by either by an echo or also by an invasive LV cath. But heart also is understood or can be characterized as a tissue pump, where because it secretes some biomarkers like BNP, anti-proBNP, some cytokines. And we now understand that it is so very important clinically to look at a patient as a whole, looking at the LV performance by looking at the anti-proBNP levels also. And heart also is a muscular pump, looking at the twist and untwist mechanics, the contractility, which we identify by looking at the strain imaging. Strain imaging, you can do either by an echo or by cardiac MR. So the concept of cardiac performance has evolved over a period of time, and we as imagers should know this concept. Now, the most common, most important, and most famous entity in echo is ejection fraction. And ejection fraction is nothing but the amount of blood which is pumped in every cycle, every beat, divided by the end-diastolic volume. And remember that heart has the ejection fraction is load dependent, preload dependent, afterload dependent, heart rate dependent, and it also has variation. So it's very much mandatory that all echo reports should always have a mention about the heart rate and also the blood pressure. This because the ejection fraction, these are dependent on this parameter. So every report should be mentioning these two entities. Now, the previous chamber guidelines, which came in 2005, uh, gave this values of ejection fraction. But now in 2015, almost 10 years back, the values have changed. The EF normally is more than 52%. It can be mild, moderate, severe LV dysfunction depending upon the EF. So this has to be remembered, but I'm telling you that we are expecting a update about this chamber guidelines, which came from the American Society of Echo next year, and we are expecting some additional changes. So what exactly is basically ejection fraction? And I will come to you. And we did publish some data about our own Indians, which is the normogram, which is came in the India study, and it had the same similar value. So the overall population, which was assessed all across India from multiple centers, showed that our normal EF is almost 61% plus minus 6. So these are the values. You can go and read this journal. So what are the different systolic function variables we are aware of? The first which came was by M mode, which is nothing but fractional shortening. You have tie index, we have ejection fraction, the very important stroke volume, cardiac output, and cardiac index. You can also have systolic velocity assessment at the mitral valve by tissue Doppler. You can have regional valve motion abnormality. So all are these variables which can give you an understanding about the left ventricular systolic performance. And this gives you some way of the idea. But the most important thing which I will emphasize is that we should remember ejection fraction. We should always give information about stroke volume, cardiac output, and cardiac index. And we should always assess the regional wall assessment. Now, this cartoon on the right side shows how the heart churns, showing that the fibers are moving in both clockwise and anti-clockwise. The apex moving in the anti-clockwise and the base moving in the clockwise. So there is a churning which is occurring and which keeps on going lifelong. Now, if I give you this echo image of a patient, and this is an apical three-chamber view and apical two-chamber view. Remember, the apical three-chamber view and two-chamber view and four-chamber view gives an orientation of the fibers which are longitudinal. And we have seen that a lot of people still give an information of ejection fraction by visual estimation. I will encourage not to do it because it is experience operator dependent, but you may overlook subtle findings, and it's very subjective. It's a good idea to give this ejection fraction number by biplane Simpson method, but a visual estimation should be avoided on a day-to-day practice. All ECG, all echo should be ECG gated. Every echo should be ECG gated, which gives you an idea about the loading condition, as I had told. So the ejection fraction definition is nothing but the end-diastolic volume minus systolic volume divided by LV end-diastolic volume into 100, and it is accepted globally, and this can be identified, this can be calculated by a Simpson's formula or a modified Simpson formula. But the problem is this doesn't give you an understanding of subclinical LV dysfunction, so it has its own limitation. But every report should give you an information of ejection fraction. Now, we have the first chamber guidelines, which came in 2005, gave the LV ejection fraction by M mode. But the 2015 guidelines shows that ejection fraction assessment by M mode using the TCOX formula should be avoided, should not be done. And it is a good idea to not do M mode measurements about the dimensions, because you may not many times cut the plane perpendicular in parasternal long axis view. So the recommended thing is to do by biplane Simpson's formula. Now, what are the other variables of LV systolic performance is by looking at the stroke volume. Stroke volume is normally around 50 to 90. And the way you do it is by looking at the LVOT diameter. It is nothing but LVOT diameter square into 0.785 into LVOT VTI in apical 5-chamber view. The values of LVOT diameter is around 1.8 to 2.2, and VTI is around 18 to 22, and these are the ranges. This gives you an idea how the LV is performing. You can get cardiac output by multiplying stroke volume into heart rate, and you can get cardiac index by cardiac output by divided by body surface area. So these are very important things which gives you an idea of the LV performance of the heart. The other thing which I mentioned, which gives you a rough idea, is looking at the tissue Doppler velocities at the medial annulus or the lateral annulus by looking at the S velocity. So the S prime gives you a rough idea of how the LV is performing. Of course, it has got its own limitations. It cannot be used in patients who have a lot of calcium over there. But a rough value of more than 8 centimeter per second of the medial annulus, S prime, gives you an idea that the LV function must be preserved. So you can still use it in few patients, but understanding there are few limitations. The other parameters which has been there is looking at the cardiac power output, which is nothing but the multiplication of cardiac output into MAP, and there is a constant. This gives you a good idea about the cardiac performance, but it has its own limitations. You can also look at these findings, but we don't use it routinely on a day-to-day practice. The only thing which you do it is in research performance. But I will suggest that there are some papers where they have looked at the power output, which is nothing but the multiplication of cardiac output into mean arterial pressure, and there is a constant. But over a period of time, we have realized that there is more to LV ejection fraction, and that is looking at the strain analysis. Strain analysis has come up strongly, which gives you an idea of subclinical LV dysfunction even before the LV ejection fraction is normal. So what exactly is a strain? Strain is nothing but looking at the contractility of the fibers. As I have mentioned, that LV left ventricle has got predominantly three kind of fibers. One is the longitudinal fibers, radial fibers, and circumferential fibers. The radial fibers and circumferential fibers are seen in parasternal short axis view, but unfortunately, there are some limitation in its standardization. So I will suggest that we don't routinely use. It is only used for research purpose. The most important thing which we at this moment of time everybody should know is looking at left ventricular global nonsus strain, which tells you about the function of the subendocardial fibers and can be picked up by apical 4-chamber, 3-chamber, and 2-chamber view. So this is one diagram showing how the longitudinal strain is analyzed, and this shows that it gives you an idea about the health of the subendocardium. And the normal value is always negative because it is contracting away from the apex, and anything which is going towards positive, towards minus, so normally is around minus 19. Anything which is towards minus, more minus 20, minus 21 is a healthy subendocardium. But if it is going below minus 16, minus 15, minus 12, we are dealing with there's some problem in the subendocardial. Those LV strains are going down. So this is a very robust parameter which has to be understood in identifying LV function. So as I said that the myofibers in the left ventricle are of three types: longitudinal fibers, which are mostly apical, and they give you the subendocardium, while the short axis view gives you circumferential and radial fibers. Remember that we only need the longitudinal fibers, which gives you an understanding about the global longitudinal strain. So as I said, strain is nothing but a contraction, and once there is a contraction, it is always identified as negative. And this again shows the different types. This is long axis, this is circumferential fibers, and there's the radial fibers. So we have to remember the longitudinal strains only. So let me show you a couple of cases, and let me tell you how this LV ejection fraction is. We use it on a day-to-day basis. So this is a male, hypertensive, on and off having chest pain, had a family history in father of coronary artery disease, occasional smoker, cholesterol was 196. So this patient had chest pain. We got the echo. The echo looks pretty good. By biplane Simpson was 62%, preserved LV function. But this patient was telling of chest pain. So when we got more information, the E by E prime was 10. You can see the E velocities are preserved the S prime velocities are preserved. But once we got the strain imaging on apical 4-chamber, 2-chamber, and 3-chamber gives you an identification of a bullseye pattern. So this bullseye pattern, the values were lower. It was like minus 12.1. And there was some pattern which was showing, ideally it should be completely red. But here there was some filling defect, there was some problem. So this gave us a clue that we need to take him into the cath. And we got an angiogram. And the angiogram showed a tight proximal circ territory stenosis. The LAD it was normal. So the biggest advantage of strain imaging becomes that even if the LV function was preserved, but the subclinical LV dysfunction was picked up on a bullseye where the echo was looking normal. Now, the second important thing is a concept in heart failure. And as we know that HFpEF, which was earlier called as diastolic heart failure, is almost around 50% of all heart failure. So let me show you a case. So this was a male who was hypertensive, had breathlessness and YH class 2, an obese, overweight of 29, had cholesterol of 202 and HDL of 32. So when you start looking at the echo, this patient had a hypertensive thick heart with interventricular septal thickness of almost around 14, and the LV function looked pretty good. You can see a good contractile LV. The angiograms were normal, and we looked at the strain imaging, and you saw that the strain imaging was lower. So as I said, the global launch strain normally is minus 19. In this patient, it was almost at 11.4. So this is an important thing which you have to identify. So this was a patient who had some heart failure changes, hypertensive, but had global launch strain going down. So it was around minus 12. So what are we dealing with? We are dealing with changes which we showed that there are early impairment of LV function in patients of young hypertensives by strain imaging. And once you start treating this group of patients with an optimal antihypertensive therapy, they may have a reversal of their strain, and they can have a normal life. So it's very important that you pick up subclinical LV dysfunction. So the heart failure component, the HFpEF component has grown up. I'm sure there will be a separate topic, but it is very important to understand that the LV assessment of ejection fraction divides heart failure into HFpEF, HFrEF, heart failure with mildly reduced ejection fraction, and also heart failure with supernormal EF, where the EF is more than 65. So the HFpEF group can have a predominant involvement of cardiac, where classical is an infiltrative cardiomyopathy. But you can also have heart failure because of HFpEF, because of extra cardiac component. And this HFpEF subgroup has now even been characterized by more of looking at the anti-pro-BNP. So the phenogroup 1 is BNP deficiency, 2 is the classical obese, and the third is patients who are HFpEF with either RV failure or atrial fibrillation. Now, why this is important, that ejection fraction going beyond them is important because their prognosis is very poor if you have a phenogroup 3. Now, let me also give you a third case, moving on to the spectrum of ejection fraction to a valve. So this is a female who had rheumatic heart disease, had breathlessness and YH class 3, BMI of 21. And as you can see, had a severe mitral stenosis of 0.9 mitral valve area. The LV function looks pretty good. We did the ejection fraction, but it was normal, but the strains were around minus 15, minus 16. The global was around minus 14.1. So she was subjected to BMB, and this is the paper which we showed that irrespective of the ejection fraction, or irrespective of the strain, if the valve is pliable, it should be opened up, because the EF and the strain improves after PTMC. So this was an important paper which showed that after PTMC, the LV ejection fraction or the strain improves in patients who have isolated severe mitral stenosis. Now, the importance of ejection fraction and strain analysis or understanding LV performance is robust in the field of cardio-oncology. And I will like to emphasize that this is a condition, this is the entity where it is called CTRCD, cancer therapy related cardiotoxicity, because the drugs which are used in various malignancies are cardiotoxic. So the last recommendations, and there is some new advances which has come up, emphasizes that all these things should be done. So there is a requirement that all the measurements of patients who are going for cancer chemotherapy should have an assessment of ejection fraction surely by Simpson's method, either by 2D or by 3D. We have to provide them with LV volumes. You can do CMR in few cases. All patients should have an NT-proBNP and troponin when they are coming for a cardiac checkup or an echo. So biomarkers are mandatory. Give the loading conditions. So blood pressure and heart rate are important. And if facilities are available, you should have an LVGLS assessment. So ejection fraction, never by M mode, never by eyeballing, always by biplane Simpson, and also GLS. So this is the principles of understanding of assessment of cardiotoxicity imaging, which is important. So this is a patient who had before chemotherapy. I'm giving you two examples. This GLS was minus 18.5, and after chemo was 16.5. So there was some change. And the second patient before chemotherapy was 19.5, and after was 10.1. So what is significance has to be identified, and they have defined that if there is a decrease in the reduction of GLS by more than 15%. So let's say initially the GLS is minus 20, and next time if it goes to minus 16 or minus 16.5, then it is called CTRCD. So the 15% relative reduction is important to identify cardiotoxicity. Now, you can there is a clear-cut definition of CTRCD. So if there is a drop of ejection fraction of less than 10% point to cut off of 53%, it is CTRCD. But if there is a drop is not there, go for GLS. If the GLS drop is more than 15%, then you are dealing with this. So these are the important thing. So I'm just trying to emphasize that LV ejection fraction and GLS are the most robust parameter to be identified in patients who are getting cancer chemotherapy or chemotherapeutic drugs. Now, there are various protocols I would like to just pass by fast. The one is the anthracycline protocol. And if you see here that on the lower down, patients should have the transthoracic echo along with the biomarkers. So it has to be done at baseline, before second cycle, before fourth cycle, sixth cycle, then 3 months and 12 months. It's very clear. 0, 3, 4.
इसने कोई गंदी रख दी तो
Actually, you have to mute yourself, please. Yeah. So the transthoracic should be done. So it should be done at 0, second cycle, fourth cycle, sixth cycle, then 3 months post, and then at 12 months. And every time you have to do an NT-proBNP. But for HER2 target, the things are slightly different. You have to do transthoracic at baseline, 3 months, 6 months, 9 months, 12 months, 3 months post-treatment, that is 15 months, and then 2 years. So it is baseline 3, 6, 9, 12, and then 15, and then 24 months. And every time you have to do NT-proBNP and troponin. So these are the ways they have, these are the ESC guidelines. And every time we have to give ejection fraction and strain parameters. One more case. So this is a patient who was obese, came with NYHA class 3 symptoms. And as you can see, it looks like a thick heart, very hyperechoic, very bright things. You can see that the LV function looks pretty okay, but once you do the tissue Doppler imaging, you have this 555 signs. That means the E prime is less, A prime is less than 5, and the S prime, which is normally more than 8, is also less than 5. So 555 sign indicates that the LV, the longitudinal fibers are moving very less, is associated with poor prognosis. And once we have the bullseye imaging, it shows an apical bright or a cherry on top, which goes mostly in favor of an amyloid picture. Of course, can be seen in a lot of things. So a pattern of strain imaging or bullseye gives you an idea how we assess the thing. So this is about left ventricle assessment. But so what I will suggest that you have to always give the heart rate. We have to always give the blood pressure. Try to get an idea by looking at the biplane Simpson's method. And remember that the eyeballing should be avoided, M mode should be avoided, and always we have to do a GLS in every patient. Now, coming in maybe in either 1 or 2 minutes, I would like to tell that we, along with LV, should also look at the left atrial performance because the LV assessment should be done in an LV focused view. LV focused view is a way where in apical four-chamber view, the LV apex becomes conical and the LA is cut as half. So the LV focused view should have an LV apex, which is apex should be conical. But there is something called LA focused view. The reason I'm coming to it is that it has to be, whenever you try to have an LA focused view, the LV apex has to be foreshortened. That means you go slightly one space above and make the LV apex rounded. So the LA becomes big. So because the axis of LA and the LV are at different levels. So this is important to understand that LV assessment should they should be with LV focused view. So all measurements should be with LV focused view. And the LA gives you an idea. You can look at the LA volume and you can also look at the left atrial strain. I will not go in details, but the left atrial strain can be done by RR gating or PP gating, where most of the time it is by RR gating, where all the movements are positive. And this is how the left atrial strain looks like. It has got the first peak, which is nothing but the booster, or it's nothing but the reservoir strain, which is called the PALS, peak atrial longitudinal strain. And the last one is the green one is the booster strain, the peak atrial contractile strain. And in between is the conduit strain. So most important assessment of LA function is looking at the reservoir strain, and the second is booster strain. There are some work values I've given, which are looking at the left atrial strain BLS of around 38. 38% is now considered to be normal. Anything less than 25 is bad, and anything less than 18 is really bad. So we start looking at the LV function and LA function, and we have done a lot of work where we have looked at the left ventricular performance, and you can go and read all these values. So let me conclude is that the LV ejection assessment is an important part and should be there in every report, understanding that we have to mention heart rate and blood pressure. Should be done always by biplane Simpson. There are automated methods, there are manual methods. Whatever you are comfortable, go for it. Try to do it by LV focused view. Please stop using M mode. M mode is not acceptable. If you have strain, which is nowadays mandatory, it gives you an understanding about subclinical LV dysfunction in various settings, and it helps in management of our patient. Remember, we are looking at the GLS, and anything around -19, -20 is normal in healthy patient. Thank you so much. I think let's have some discussion and questions.
Wonderful session. And Dr. Simi, do we have questions there in the chat? Is it mandatory to have GLS in every patient with diabetes to detect microvascular coronary artery disease? That's for Dr. Shantanu, please.
Yeah, I think it's a very important thing. Point is, see, echo is basically a tool which gives you an idea about the patient's problem. So if you're suspecting a coronary problem, so as I said, that diabetes is one of the causes of heart failure, HFpEF. If the ejection fraction is normal, and if you have the GLS going down -16, -17, then you are identifying an entity which is called heart failure with preserved ejection fraction with low GLS. I didn't mention about all of things, but yes, at least once a year you should do a GLS, and this can be a tool, but where you can pick up microvascular dysfunction or HFpEF in this group of patients. So if you have GLS with you, you have to do at least once in a year to see the patient. It's a good idea to report.
Very
Shantanu,
wonderfully said.
can I have a question, UP? Can I put
Yes,
a
sir, please
question?
Yeah.
go ahead.
See, whatever modern parameters you have told, like strain imaging, 3D, GLS, and all this thing, now they are operator dependent, they are image dependent, and they require very expensive equipment. So, and they are also dependent upon image quality. Then ultimately, if for a normal person, can we have many conventional parameters which are used in a day-to-day functioning? For
Yeah. So
example, what about the corrected MAPSE or a MAPSE? Because this also gives a longitudinal thing. So a
yeah.
person who is not having these equipments or those things, what are the conventional techniques he can use to get this?
Yeah, so I think I got your point. So he's talking about MAPSE. MAPSE is also a robust parameter, but it is very clearly indicated that it has to be used only in critical care setting where the patient either is intubated and where you have difficult time in identifying strain or anything. MAPSE is a good parameter, but it has got its own limitations. So, but I think what I feel is all machines now have at least tissue Doppler. So if tissue Doppler is there, it gives you an idea. LVEF, MAPSE, and look at S prime. They give you an idea what is happening. But yes, MAPSE can be used if you don't have strain image.
Because now they have come with the concept of, because the MAPSE depends upon age, body surface area, LV dimensions. So they found it as a very robust parameter, even if imaging is very poor.
Yeah.
And they found that it had a good prognostic value. And then they came up with a corrected MAPSE in which they say you take an average of MAPSE divided by the end diastolic length of the LV, which covers the LV sort of a deformation, and that has got a fairly good correlation. So I'm talking of a general person who is not used to or who cannot have the specific equipment to some of these conventional parameters. And there's a lot of recent papers on MAPSE and the corrected MAPSE and its relation to ejection fraction, especially
I
in
absolutely
emergency
agree.
situations.
Yeah.
So I think
Yeah, absolutely agree with you.
this
MAPSE.
should not be completely condemned.
Yeah, absolutely. I agree with you. MAPSE has now recently come up, especially in the critical care and the POCUS thing, where they try to index it to BSA and also the LV longitudinal dimension. Yes, I absolutely would like to accept that. Yes. So there is one more.
There's another question, and that's a difficult one, Shantanu. How do you assess a systemic ventricle in CCTGA?
I
Meaning that
think
systemic ventricle is RV.
Dr. UP Singh, you are a better person to answer than me because you
I think
see
even
more.
I don't know. See, I tend to diverge from the concepts of TAPSI and MAPSI. I reviewed TAPSI and I found out that it was a very lousy method of assessing at least RV functions, and I think it should be true for the LV as well,
So,
because there's many
yeah. So,
parameters. So I'm coming to CCTGA.
yeah.
Yep, you
So,
first.
Dr. Parashar, I would like to add to what you said. So, MAPSE is now basically and TAPSE is now being taken by critical care specialists for POCUS. But there's a recent review article from Luigi Badano and Deniso Moraro. They have condemned and they have said that TAPSE and MAPSE will not give you an idea about the ventricular performances and should not be used because both the methods are
See,
very much
there are certain
angle
There are
dependent.
certain papers in 2025 in
Yeah.
which they have said because many other imaging limitations are there, but they said this doesn't have any imaging limitation.
Yeah, I think I agree
Suppose you
with
are
you.
doing an emergency bedside echo, you cannot do those things. You have to rely on this MAPSE, and they have correlated it with there is a paper in which they have correlated even with this MRI also. So
Yeah.
even the last paper in 2025, where UP said it should not be condemned. Even TAPSE is all right. You have to do various methods, but once you have got no other method, then it gives a good correlation. It has got a fairly good studied with the in this corrected MAPSE has been slightly compared with the global longitudinal strains also. So I think in because the in every bad imaging, a MAPSE can be used in any imaging, and it is a very sort of a easily obtained. And you so this, but otherwise I said ki because nothing like strain what you have said in myocardial work also, but in a
Yeah.
day-to-day functioning for an average person who doesn't have that expensive equipment, what I mentioned UP was everybody doesn't have the facility of this 2D strain, 3D and all the in those patients. Because when we do a clinical round, we are not only using the high flown cardiologist, but a usual person. So if we condemn MAPSE, then they have nothing to let with. Stroke
Right.
volume is very important. So that was my point also.
I agree with you, sir. I agree with you. Yeah. So I think what
Yeah.
else?
So there is a question on how to report GLS, and then what do the colors indicate in the bullseye? If you can take up
Yeah.
that very quickly, Dr.
Right. So I think there is something called Nyquist limit in GLS. The Nyquist limit gives you, if you see on the right side and above, it is plus 20 to minus 20. Plus 20 is towards the blue side, minus 20 is towards the red side. So the colors in bullseye, if it is completely red, it defines that it is going more negative, minus 19, minus 20. But if it goes towards positive, it is towards blue, then it will be towards more towards positive side. I hope so. If you have a strain thing, just go and look at the Nyquist limit. It is plus 20 to minus 20. Minus 20 being red,
So basically, if it is red, that means the LV function is good. If
healthy,
there are some colors of blue, that means there is some jeopardy there.
or less red is it's a bad. It is
Bad.
going. Yeah.
Okay. So how do you report GLS? If you can just tell in one line, how do you
Yeah,
report
so
GLS?
GLS should be global longitudinal strain. So it should be a mean of all the three. So don't take the values of regional strain because regional strains values are not validated. So the bullseye gives you a value, let's say minus 16.1. But if one region gives you minus 20, the other is minus 12, don't report them. Only the global one.
Okay.
Should GLS be reported in every echo report nowadays, Shantanu?
I think if you have the facility, it is a good idea to do it. because it is more reproducible. So I think one paper, and I think Manish is also here. He was, I think, a part of it. The reproducibility of LVGLS is very, very high. So if you have the facility, I think it will be a good idea to do it, because the 2015 guidelines have accepted the value of LVGLS. And I'm telling you, next year, I know about the thing, the guidelines are going to be added up. So they are pushing that this should be given in every. If you have it, there is nothing like it.
Yeah, it
It's a
That's
actually
very,
the
very
is
reason.
controversial question. This the GLS, now it has so much of work has been done on GLS in various valvular heart disease, especially aortic stenosis. Now they find it is much reduced. In a normal person, they say that okay, if it is below 50, do surgery. But when will this GLS come in a valvular heart disease thing also, that it's the importance also?
Yeah, I think for the valves, there is a lot of work, but I agree with you. The guidelines still are not incorporating. I absolutely agree with you. So I think we have to be very careful. But my point is, if you have it, it's good to give it information.
So in continuation with that same question, what should be mandatory versus optional in a routine echo report? This is for the general public,
Wow.
listeners. So what should be the mandatory versus optional in an echo report, in a
So
routine
I
echo
think
report?
let's talk about the LV function only, because the echo
Okay.
report can
Yeah,
be
LV
everything.
function only I'm telling.
So
So
I think
based on the LV function,
mandatory,
what you want to give?
all echoes should be done on an ECG gating. Very important. So try to give the heart rate and the blood pressure. Try to give LV ejection fraction by biplane Simpson's method. You should also give, if you have GLS, that is optional. I think I will not put it mandatory. But if you have GLS, please give it.
Hmm.
What else?
Okay.
I mean, sir has said MAPSE, if you are unable to do an LV ejection fraction by biplane Simpson, then yes, you should look at the MAPSE. It is very helpful in the critical care setting. Also, look at the S prime, gives you an idea how we're doing. But I will suggest stroke volume is a good parameter, stroke volume index. It can help you in giving the cardiac output. Stroke volume is very easy to be done. And if you have,
Yeah.
what else? I think
I think
this should be
LV
sufficient.
volumes also need to be,
Volumes, yeah. But
yeah,
because if you get
more.
ejection fraction, the LV volumes you get automatically. I agree with you.
So you
Yes.
had mentioned in your initial part of the talk itself that these mandatory things are the volumes and the ejection fraction by Simpson. And if you have strain imaging, I think you should report it and then follow up. That's what
Correct. Correct.
is your summary, I guess. This one
Would
question from my
say
side. Hmm.
what
Please conclude.
Shantanu what Shantanu very nicely said. Now every echocardiographer should practice to do a stroke volume. It will be used in aortic stenosis, it will be used in mitral stenosis, and various conditions in which a stroke volume index is given. So that is rightly pointed out by him that every echocardiographer should start practicing a definition of a stroke volume and all this. And do you prefer a BSA in every case, body
Yes,
surface area, or what do you
yeah,
prefer?
BSA is good. So I would like to, so let me give you an understanding. So this India study which we published, the next in March 2026, there is a multicentric work which is coming up, and the first author is Jodie Wang. So she took our data and she's looking at everything what is happening. So I think the next guidelines are going to that BSA should be given. And let me tell you, in all our echo machines, if you put the height and weight, the BSA comes. So there is no harm in trying to explore our machine and try to do it. Is it mandatory to give in all the patients? The answer is no, but you should be aware of this BSA concept.
Yeah.
Yeah,
Thank
let's.
you.
Yeah.
There's one question from my side, Dr. Shantanu. So we see a lot of heart failure patients, and then we do routine echo, we do NT-proBNP, etc., etc. So where should strain fit into the guideline-directed medical therapy pathways? So do you have any recommendations so that those who are doing strain imaging, so they can incorporate this in their routine practice?
So let's say if you have a patient who has HFrEF and his ejection fraction is 20%. Looking at the LVGLS will not give us any advantage because it will be -9, -8. It is not giving you any idea. So if you have a burnt out EF of 20%, LVGLS doesn't give you an idea. But let's say if you have a patient of LV HFpEF ejection fraction of let's say 55, 60%. If the strains are normal, if the strain is -18, you're looking at a condition called primary atrial cardiomyopathy. So you'll start looking at left. Where is the problem? Second thing is, this is one entity. Second thing is, understand that the heart failure group keep on changing. So the HFpEF patients can deteriorate, HFrEF can improve. So if a patient of heart failure is improving, you don't stop the drug. So prognosis is very important. So I do all patients of heart failure with mildly reduced ejection fraction, 44%. But if the strain is improving, you have to tell the patient that, and there is a pretty good correlation. I mean, we have to understand that NT-proBNP also helps us. So I think I'm also now looking at an entity called heart failure with supranormal EF. Okay, so this is an entity which has been reported by ES. We don't know a lot about it, but I think it's a good idea to look at them. I hope I answered your question.
So what I understand is there is some role for the strain to guide us in our medical therapy of patients of heart failure. So if we're doing it regularly, it will definitely help us.
Yes, yeah, it's amazing.
Okay.
So we have
no,
patients. Yeah.
Just one question. I have attended some workshops on what they do. They rely only on automatic thing. But how often do you do some manual adjustments also in these high-end machines rather than only depending upon the automatic sort of a doing a GLS also?
I absolutely agree with you. So let's say if I take the G platform,
जी खाना बाद में अभी हम नीचे ही आ रहे
so
हैं
the
पहले हमको
if
एक ये ला दिया बस हम नीचे आ रहे हैं हो गया काम एक ये ला देगा हाँ
so
I see.
if I do GLS in a G platform, I have to manually change the GLS, and I have to put it because the GLS in G starts slightly below the annulus. So it's an important idea to pick it up. But I just recently saw the new machine, the premier entity, it has been removed. So it is very important to understand and look at how the tracking goes. But if you have a good image, the reproducibility is pretty good. And the recent work shown that the reproducibility earlier, which was 3.3, now has been reduced to so intervendor difference, which was earlier 3.3, now has gone to 0.6. So it is a pretty good AI-driven model if you have good images to get the GLS.
Okay. So this one from my side for all the echocardiographers who are there attending this seminar. So what should echocardiographers focus on mastering in context with the LV systolic function assessment? What should they focus? So
so I think they should focus on doing all echo with an ECG. That is very mandatory. Correct. Have a blood pressure always, because these are all load dependent changes. Third is you should try to look at the stroke volume. Stroke volume has again come up very strongly. It's a very robust parameter. Try to do biplane Simpson's method of ejection fraction. Stop M mode. I mean, do I do M mode? The answer is no for EF. Third is whenever you are getting ejection fraction values, please, as Dr. Simi was telling, please look at the volumes, because volumes gives you an idea what exactly is happening. And if you have GLS, try to go for it. MAPSE can be looked at, TAPSE can be looked at in a critical care setting when you cannot do an ejection fraction, when you're not getting good images. MAPSE gives you an idea. Anybody would like to add here? Dr. Bora, UP Singh, Dr. If I missed anything.
I think I would
One
add.
question which I have one question which is not relevant to this talk. How often do you do a myocardial work in your daily practice and report it? Because you do a lot of myocardial work. So how often it is done?
Yeah, so I think what myocardial work index is, let me tell to the audience, is nothing but looking at the interplay of GLS with the pressures, with the aortic pressures. Do I do myocardial work index on a day-to-day basis? The answer is no, because it is only for research purpose. The
Yeah.
problem is it is only available with one vendor, but there are some challenges which we are facing. So, do I do it? The answer is not regular, only for research purposes.
No.
But for
Let's thank.
practice
That is good.
purpose, yeah, I do it
Good answer.
one patient every day so that I don't forget the thing. That's the point.
Very, very practical answer.
Yeah.
Yeah. UP Singh, anything from your side before we go off?
So I would for the young echocardiographers and those who are beginning to do, and even at a level when we've done about 3 or 4 decades of echocardiography, we generally have no problem telling that ejection fraction is 35, 30, and it doesn't really make a difference if I say 33 or if I say 28 or 25 or 26, except for some therapeutics interventions. But the problem happens when the ejection fraction is between 40 to 50 or 45 to 55. That is the major challenge where variations happen and the treatment also tends to change. I suggest few tricks there. One trick is that go to parasternal long axis view, do an M mode, look at EPSS. If EPSS, E point septal separation, our old friend, is less than
Yeah.
0.7, then we are happy. The ejection fraction is normal, whatever the regional wall motion not be, maybe. The EPSS is a very good, indicator. So you can kind of confirm your, echo ejection fraction. Second, if you have GLS, then if you use both the methods, let's say ejection fraction is you are looking at ejection fraction of 45 and GLS is 20, this is not compatible.
Well,
So that means you are wrong in ejection fraction. You can't have low ejection fraction and normal GLS, right? Vice versa can be there, but so then these are kind of counter checks which you should use. I don't think so. Depend upon a single method in a mid range or a borderline ejection fraction. There, all these tools really come to a great help. And it was a wonderful webinar. Thank you, Dr.
I
Shantanu.
agree with you, UP Singh. It's an amazing, important talk. APSS has its own advantages, and I think it's a good idea to take 2 or 3 types of measurements to verify whether you're doing it properly. That's very important. Correct.
Over to you, Dr. Simi. You want to do some closing remarks?
Thank you, all the participants. It has been a wonderful interactive session and good kickstart, I should say, in the new year. And looking forward to more
just
interactive.
say one thing that his comment on EPSS was very important. His comment on EPSS are very important. There was a very important paper published in 2012 in which the EPSS was correlated with MRI-dependent ejection fraction. And they reported that at what level, what was the ejection fraction. So they never gave an importance. They gave a lot of importance in EPSS. And they said that when it is more than 80, that means they say for more than 30. They compared it with this. So I think it should be done, except in cases of mitral stenosis and aortic regurgitation or so.
Yes.
Who is now?
Thank you for being a part of the seminar. And I think we can all leave. Thank you and good night. Shubh Ratri.
Thank you. Thank you so much.
Thank you. Thank you.